cortices of the tibia and the surrounding soft tissue were leading to difficulties making confident clinical decisions. So I did a bit further work and found out that the default protocols were set based on a combination of the manufacturer's advice, previous staff experiences, and the 1996 European Commission guidelines. Now, these guidelines were published when film screen systems were still primarily being used, and they generally encouraged a higher kV and additional copper filtration for all paediatric projections. However, digital detectors have numerous advantages over film screen. Firstly, film screen is limited to the fixed detector dose in order to display the optimum contrast, whereas film screen has a wide dynamic range, meaning that the contrast can be displayed no matter what dose is absorbed in the detector. The only limit there is in terms of dose reduction is that as the dose is reduced, the noise starts to increase up until a point where the system moves away from being quantum noise limited and the electronic noise begins to dominate the signal. So after completing a literature review, I found one relevant paper in terms of digital imaging of paediatric extremities, and this was some work by Philips. It's a white paper, and they used a small block of PMMA and a thin strip of aluminium to simulate a paediatric extremity. And the results of this suggested that actually you could remove this copper and lower the kV and get better image quality. So the first question I had to answer was, can the exposure parameters be changed to result in an improved image quality? Well, we've seen that removing the copper filtration, lowering the kV, you're lowering the beam quality and therefore improving the inherent contrast in the image, because a higher proportion of the interactions occur via the photoelectric effect. And the white paper suggests that this improvement in image quality and the contrast is not associated with an increase in the noise, because the receptor dose only actually decreases by 10% when dropping down from 57 kV to 40 kV. The next question I had to answer was whether or not this improvement in image quality could be achieved whilst keeping the patient dose fixed. And the only critical organ in a paediatric extremity is a very small fraction of the red bone marrow, and they offer very little attenuation. So these lower energy X-rays that would normally be absorbed in the superficial tissue are actually contributing positively to the image. So there are a number of ways to define both patient dose and image quality. So prior to initiating the study, I had to decide which two metrics I would use. So the effective dose was the most relevant for patient dose, as it's directly related to the risk of radiation-induced stochastic effects. So I used PCXMC version 2.0, which is a Monte Carlo simulation software package. I computed the effective dose for a lateral ankle of a 1-year-old patient at a range of different beam qualities for a fixed input air curve. For image quality, you need high contrast and low noise, and therefore the contrast to noise ratio is the best parameter to select for the image quality. And it's simply measured between the signal between two adjacent regions divided by the noise in the first region. So I've managed to borrow an infant foot phantom, which consisted of real paediatric skeletal structures formed into a water equivalent material. And I was able to expose this to the default parameters on the Siemens Axiomaristos digital radiographic system, which were for a 1-year-old, sorry, a 0 to 1-year-old, so infant lateral ankle exposure. And the factors were 55 kV and 1.4 MAS with this additional 0.1 mils of copper. I then exposed the phantom to a range of different kVs between 40 and 64.5, with and without the presence of this additional filter. But what I managed to do was actually fix the effective dose for all of these exposures by modulating the MAS for firstly the tube output differences, and then secondly the computed effective dose variances across the different beam qualities. And then the contrast to noise ratio was simply measured by tracing a region in the distal end of the tibia and then one in the adjacent soft tissue. So the results are indicated here with the contrast to noise ratio on the y-axis as a function of the tube potential on the x-axis, with the dark blue markers indicating the removal of the copper and the light blue with the copper there. And as you can see quite clearly, the highest contrast to noise ratio, and therefore the optimum technique in this case, was found at the 40 kV without the additional copper filtration. So in order to try and give you an idea of what the difference in the contrast to noise ratios actually do in terms of the image quality, I've taken the highest value that we got, which was 12, and the lowest value that I got was 6.3. And using identical pixel value and noise data that I obtained from the phantom images, I've simulated the two images in image J, and displayed them at the same window level in order to try and demonstrate how actually the contrast and noise ratio does affect the image quality. And hopefully you can clearly see that the image on the left there has got better contrast and much less noise than the image on the right. And again, although these are only JPEG format, and ideally we'd be looking at these as a DICOM file and a workstation, window level at the same amount. On the left-hand side, we've got the 40 kV and no copper, and on the right-hand side, we've got the default 55 kV with the copper. And again, it's quite clear, even from a JPEG, that there's improved contrast in the image on the left-hand side and less noise. So the next stage in the project was to get 3 consultant radiologists and a reporting radiographer to assess the image quality subjectively based on the European Commission guidelines. So we used a 3-point scoring scale for 4 different parameters. They were sharpness, noise, cortex trabecular pattern, and overall acceptability. So we had 12 images in total, the 6 different KVs, each with and without the copper filtration. And we took the mean total score across all 4 observers for each individual image. And the display again in terms of the graphical results. On the y-axis we've got the mean total image quality score, and on the x-axis we've got the tube potential. And again it's clear to see that the perfect score of 12 in this case was obtained on the 40 kV and no copper filtration. So it seems that the optimum setting for this particular projection is 40 kV and no additional copper filtration. I firstly confirmed this with quantitative contrast to noise ratio measurements, and then confirmed it qualitatively using subjective clinical image quality analysis. So the old European guidelines encourage this additional copper filtration for the majority of paediatric projections. However, a paediatric extremity offers very, very little attenuation, and there are no major superficial radiosensitive organs in an extremity. So therefore, removing this copper filtration actually didn't increase the skin dose. It actually gave us a better image quality because more of the photons were able to contribute to the image in a positive way, and therefore improve the inherent contrast and give us better image quality. And actually, this improvement in contrast was obtained without significant variation in the receptor dose, and actually measured the receptor doses across the range of beam qualities, and the variation was only a maximum of 20% from the default settings. And finally, the lower beam quality doesn't increase the effective dose for this particular projection, again because only a small fraction of the red bone marrow is there. And actually, for a fixed air kerma on PCXMC, the effective dose for the default parameters is almost double that of the optimum parameters. So a lower effective dose for the lower energy spectrum, which goes against the principles that people were taught with film screen systems. So the results were really promising, and the final stage was to get some more verification of this new optimum protocol. So we managed to get some real clinical images of post-mortem babies. In this case, we had 5 observers, which consisted of 4 radiologists, a reporting radiographer, and they all scored 10 lateral ankle images obtained using the default parameters, and 10 lateral ankle images obtained using the new optimized parameters. And they scored the images in an identical way to what they did with the phantom images. So the same 4 parameters, again on a 3-point scale. And again, the results are shown here. And for the default, you can see that the mean image quality score across the 5 observers of the 10 images was 7.9 for the default setting and 11.6 for the new optimized setting. And actually, the chance that this result would have been obtained if there were no difference in the 2 images is less than 0.1% when calculated using a Mann-Whitney U-test. So we've got significant improvement in image quality, which was the original question I was asked, but at the same time we've had also significant reduction in patient dose for a large cohort of patients. And the reason for this is that the issue we were having with repeat imaging has now been resolved. They don't need to do the repeats anymore. So therefore, a large number of these young patients are having a dose reduction by a factor of 2 or even more in some cases, and less dose is being wasted on undiagnostic images. The next stage would probably be to see if there's actually any superfluous image quality. So we've got this optimum setup, but could we reduce the dose a little bit further and only get the optimum image quality that we need? And then finally, we could actually look at other age ranges. We've got a huge cohort already with just the 0 to 1-year-olds, but there's nothing saying that if we can get hold of a different size foot phantom and do the same simulations and the same calculations, that this could actually extend to other age ranges and possibly even adult extremities. So this work's now been published in the British Journal of Radiology, and last year I was asked for it to be used as an optimisation case study example in the European Training and Education for Medical Physics Experts in Radiology. The protocol has now been widely adopted in the UK, Europe and Australia, and hopefully it will continue to be adopted on a global scale. Thanks.
So we have time for a few questions, if you want, for a minimum of 2 questions. So have you had, oh sorry. Please, wait a second, please. We have time. Please.
It's difficult to believe that after 100 years, almost, of X-ray technology, that nobody has looked at this. I mean, the work is brilliant, it's thorough, it's scientific, but nobody ever thought about the small size of a pediatric bone or joint and looked at this. And the second, my real question is, why didn't the manufacturers figure this out and provide it as an addendum to the information that they provide to radiologists?
Yeah, I completely agree. And I was gobsmacked myself that I'd found something so significant, really. And I do think that there's even potential for the kV to be even lower, but obviously a lot of these systems have a minimum of 40 kV on them. So, I mean, mammography, for example, if you're using a mammography system on an infant extremity, I think it could result in a much better image.
Okay.
Thank you, Adam. Maria Murray from SRP in the UK. Do you think, because you've looked at infant ankles here, would this be able to be repeated for other anatomical areas and for older children, particularly in the extremities, because the majority of paediatrics who come to A&E departments, it's normally a broken arm, broken elbow, shoulder, etc. Could this be repeated?
Yes, certainly. I think for the same age range, any distal extremities are pretty much going to get the same benefit. Obviously, when a lot of these babies are having skeletal surveys and things like that, so I know at the Evelina in London, they're not just using it for ankles, they're using it for all their skeletal surveys of distal extremities, and I think they've even extended it to higher age ranges, but not into the older infants yet, but we're talking probably 0 to 5-year-olds, anything more than that, and it's not been verified. But if we can get hold of a 5-year-old foot phantom or a 5-year-old hand phantom, then it's something that could be done.
Okay. Is there a last question? Okay, so thank you very much, Adam.
Thank you.
For this very useful work. It's great. So now